important topic. Actually, in ACS, patient with multivessel disease, there are main issues are what to do with non-culprit lesion. If treated, what is the most appropriate time point to do it, and what to do in case of ACS associated with cardiogenic shock. If we look on the European guidelines, we know that in non-culprit lesion should be considered in acute coronary syndromes and also in cardiogenic shock with class 2A and class 2A evidence. Now, the strategies toward non-culprit lesion revascularization can be immediate multivessel PCI during the index procedure or stage procedure or conservative medication, and all have pro and contra. And again, revascularization should be based on angio or on FFR, and we have on both trials telling us what is better to do. So angio guidance as well as FFR guidance, both pro and contra. I'll not go in detail because of time. Let's go to see what the trials are reporting. Then Angioguide Trials will show that complete revascularization is definitely better than only culprit lesion in terms of benefit for the patient. And this is also sustained in long-term follow-up as shown by Culprit trial, even after 5 years follow-up is still having benefit those who underwent complete revascularization. And more recently, Complete trial confirmed the same, that complete revascularization is better than only culprit lesion revascularization. Now, if our guided PCI confirming the same, that means the trials confirming that complete revascularization, even based on FFR guidance, our complete revascularization is doing much better than only culprit lesion. And if we look on comparison between FFR guidance versus angio, there is no difference except for target lesion revascularization, which favoring a bit in terms of target lesion revascularization versus FFR. This meta-analysis showing there's no difference between FFR and angio guidance, but the latest trial, Flower Imad trial, which included more than 1,000 patients, showing again there's no difference, but there is a bit favoring angiography guidance over FFR guidance on long term. So from meta-analysis and recent trials, we can say that complete revascularization is superior to only culprit lesion intervention, and no significant differences between angio and FFR guidance for complete revascularization. Now about the time. Well, this trial is including staging in hospital, that means within 7 days, and showing that stage procedure is doing better than immediate procedure. The same also in this trial is even this trial showing that complete revascularization and immediate complete revascularization is harming in sense increasing mortality, but not the case of repeat revascularization. And finally, this sub-study from Complete trial showing that there is no difference between 7 days staging and after discharge staging if it is done within 45 days after the index procedure. So stage procedure, except in selected cases, would be better. And these reasons for stage complete revascularization are complex procedure like severe calcification, distal left main, if it's stable, diffuse disease, CTOs, hemodynamic instability, and so on. Now, what to do in cardiogenic shock? Well, from Culprit shock trial at least in the first 30 days, only culprit lesion is doing better than complete revascularization. But after 30 days, that means on long-term follow-up, there is no difference between only culprit and multivessel. And this is also coming from this trial showing that the in-hospital multivessel revascularization or only culprit lesion is doing complete revascularization is doing better than only culprit lesion. That is true only in the first year on follow-up, but after that, only target lesion revascularization will be favoring complete revascularization. And multivariate analysis will showing that only short-term mortality will be benefiting from favoring culprit lesion only revascularization, but not long-term mortality or reinfarction. So complete revascularization in STEMI with or without cardiogenic shock, beside the experience, requires a good clinical judgment. So we should take in consideration the advanced age, poorly controlled diabetes, advanced chronic kidney disease, late presentation, shock, and the extension of disease. Just some examples. I think in stable patient with culprit, like in this case, LAD and or simple lesion in right coronary can be done at the same procedure as well as in this patient, as well as this patient with the hemodynamic instability and inferior myocardial infarction, total occlusion of right coronary artery, but you see that there is a severe lesion on distal left main, and patient cannot be stabilized without doing that in the same procedure. But it is not the case in this patient with diffuse disease and non-culprit CTO. Then I think staging in this case, as well as in this diffuse disease case, will be better for the patient and more safe. So to conclude, I'm coming to the first questions. So what to do with the non-culprit lesion? Well, complete revascularization is doing much better than only culprit lesion. If treated, what is the most appropriate time point? Stage except in selected patients that from 7 to 45 days after the intake procedure will be better. And what to do in case of ACS complicated by cardiogenic shock, still unknown, because complete revascularization should be based on good clinical judgment and experience of the operator. Thank you very much for your attention.
Thanks.